Bonjour. Hello, everyone. Welcome to today's virtual peer sharing and learning session, Understanding Need, Demand, and Supply to Enable Primary Care Expansion. We're going to give everyone a few minutes to sign in before we start. As we wait, please introduce yourself and organization or OHT or PCN in the chat box. Make sure you select everyone from the drop-down so that we can all see who's joining. By now, most of you know me. For those of you who don't, my name is Leslie McGeough, and I'm a focal point and coach with RISE. We have many new people joining today. So for those of you who are not familiar with RISE, we are a free resource for OHTs and PCNs with the specific purpose of supporting them as they develop and mature. My colleague at RISE, Steve Lott, is also supporting us behind the scenes. So if you do have issues, you can message the host and he will try to help you resolve them. Welcome, Erin. Thanks for joining us today. Dr. Joyce, thank you for joining, and you'll be sharing your learnings, which is excellent. Rebecca, thank you for joining from KW4. In June and July, we shared with you a taxonomy of 9 approaches to primary care access and attachment, and today we'll dive a bit deeper, understanding need, demand, and supply to inform the mix of primary care access and attachment approaches to leverage as you design primary care models. Here's some examples of this work from the Elgin OHT, North Toronto PCN, and you'll hear a Northern perspective from our RISE co-lead, Dr. Brianne Wood. Please note, today's session has been expanded to a broader audience and will be posted publicly on the RISE website. We recognize for those of you who usually join us, this is a bit different. If you have concerns with this new approach, please feel free to message me, provide this feedback to your coach, and we'll continue to reassess how we post these sessions in the future. Want to ensure we leave lots of time for discussion today, so we are going to kick off the session. Please continue to introduce yourselves in the chat box. We'd like to begin today by recognizing we're all joining from different places across what we now call Ontario, and that we're all located on traditional territory of Indigenous peoples. As a RISE partner based in Mississauga, I'm using the Indigenous Traditional Land Acknowledgement Statement, which was developed by the Indigenous peoples in our region. As we meet here today, we are in solidarity with Indigenous peoples at Turtle Island and would like to begin by acknowledging that the land on which we gather is part of the treaty lands and territory of the Mississaugas of the Credit and before the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge the many First Nations, Inuit, and Métis people who call this area their home. We're grateful for the opportunity to be working on this land. Land acknowledgements offer a moment to recognize the role of treaty making, appreciate the land on which we live, and the importance in learning from our Indigenous community members, applying it to our ways of living, working, and being together. On the slide here is a picture of the Credit Valley River, which I enjoy walking with my in-laws. I'm thankful for those who have taken care of the land before me, and it's important to me that we continue to care for and preserve this land. I know it's been a couple weeks, but due to the nature of when our sessions fall, I do want to recognize September 30th, Truth and Reconciliation Day. As you know, it's a day about remembering and honoring all those affected by residential and day schools in Canada, a time to reflect on the lasting impact still felt today by survivors, their families, and whole communities, as well as our collective responsibility to work towards both truth and reconciliation. It's been 10 years, and to date, 13 to 15 of the 94 calls to action have been completed. As I learn of this, I reflect on ways that we can help progress these calls to action as individuals and organizations in healthcare. In my own journey, I have learned that we can help progress this change through learning about our history, Indigenous cultures, taking collaborative and reciprocal approaches, recognizing Indigenous peoples as experts in their own health, and advocating for Indigenous governed healthcare. As you continue your own learning journey and think about how you can take action as an individual or organization, we'll share some links with you from the Indigenous Primary Care Council. Like RISE, IPHCC is a free resource for OHTs and PCNs and offers many helpful supports like their health system transformation booklet, engagement toolkit, data governance handbook, and guides and fact sheets which can be used in clinic, such as ones for RSV, mental health resources, and diabetes, among others. So we ask you to please take a moment to reflect on how you can enact change as an individual or in your organization, and reflect on the Indigenous territory in your region. I'm going to pass it over now to Mike to kick off our session.
Great. Welcome, everyone. Mike Hindmarsh. I'm the lead coach at RISE. Good to see everyone on the call here, and thanks for taking time to tune into this particular peer learning session and sharing session on primary care access and attachment. Today, we're going to focus on understanding your population's needs, and for those people that are unattached to primary care, and explore strategies to assess and understand the supply and demand for primary care providers and how it affects the way that you do your approaches for attaching patients, and then exchange learnings with your peers. We have 3 of them that will be presenting today on how they've been measuring demand and supply and need, and using their information to understand how you can do a mix of approaches to attaching patients to primary care. Let's go to the next slide. Just a reminder, these sessions they're not only designed to sort of share information with you and share among peers, but they're also here to help you deliver or achieve your PCA, TPA deliverables. So this particular session here is going to be looking at how the other teams are working with primary care attachment processes that they're using, measuring supply, demand, and need. And that will help you with developing your plan for if you're submitting an EOI for the middle of November deadline, how to work with Healthcare Connect and their wait list, and how to implement and collaborate initiatives to provide clinical services to unattached patients. So just a reminder that we're trying to make sure that these sessions help you achieve your deliverables. Let's go to the next slide. So for many of you, this slide should be ingrained in your mind. We've been showing this slide for close to 5 years now. It's the imperative here is to create local accountable care systems that take the chaos of our current system on the left-hand side and create a much more organized, integrated system with primary care at the center that is managing patient populations integrated with home care, pharmacy, hospital, social support agencies, long-term care, and specialists. So that's our goal here, the big goal. Let's go to the next slide. And the way that this is going to happen is, as I said before, with primary care at the center, but we've got to make sure that we have a high-performing primary care. So a lot of the work that we're going to be doing now, in addition to attaching patients and making sure they have access, is how do we create high-performing primary care? And how do we work with teams to make sure that they have all the supports they need in order to take care of their patient populations? Let's go to the next slide. So I just want to say that over the last 5 years, all of you have been doing an incredible amount of work. And I think that what I'd like to say is that all of the work that you've been doing, while it may at times feel piecemeal, Deanne, I was just thinking about the point you made that sometimes it feels like you're doing piecemeal work, a piece over here, a piece over there. But in reality, everything that you've been doing is moving towards this high-performing primary care system. So what I've done is I've listed all the different things that you've done in your TPAs, the current work that you're doing, as well as the past work. And I think you really have to be applauded for doing this work. It's the old adage, you're building the plane while you're flying it. So I congratulate all of you for the work that you've been doing. I would be remiss, though, if I didn't put the last box in that space. If you can just hit the space key. As a population health management coach, I have to say, great job doing your population health management work also. So I think you all should give yourselves a hand for the work that you're doing. And we will get to that high-performing primary care on the right side of the screen. Oh, great. Lots of hands there. Okay, let's go to the next slide. So, during the summer, you told us about the work that you're doing around primary care attachment and access, and there were 9 buckets of work that we pulled out from the webinars that you participated in, and I just wanted to remind you of the 9. Facilitating entry of patients onto rosters, establishing additional entry points for primary care attachment, leveraging solutions that enable primary care providers to enroll more patients on rosters. There's a number of solutions that many of you have been doing already. Coordinate the expansion of primary care teams. Many of you are working on that also. Better match less intensive care models to preferences and needs for not only patients, but for providers also. Taking a whole OHT approach to increasing attachment. So this isn't necessarily just about getting people off the HCC waitlist. It's about building a sustainable process of attachment that you would have moving forward. Establishing traditional solutions to facilitate access to attachment as efforts ramp up, establishing hybrid models that respond to seasonal shifts, and improving the supply and distribution of primary healthcare providers. If we could go to the next slide. Today's session may not, well, it won't hit on all 9, but it will hit on 6 of these particular areas. And again, this is information that you told us during the summer. So when we talk about facilitating the entry of people onto rosters, a lot of your work has been doing things like engaging paramedicine and community nurses, chronic disease clinics to stabilize patients prior to initiating attachment, so that getting a lot of the intake work done up front so that the primary care provider isn't burdened with that. Frontenac OHT has been doing some of that work, and there's also a lot of work on central intake coordinators. Today's session will also help you think about adding additional entry points into primary care attachment and access. So exploring partnerships with pharmacies, again, paramedicine, urgent care clinics, hospital, EDs. A number of the teams are working on these entry points to attach patients. We have East York region. Hamilton's been doing a lot of work here on Perth. And so we also have referral from key programs from Frontenac and open door policies and service. And I'm drawing a blank on MWT, so I apologize to whoever, I can't remember who that is. And then also taking a whole OHT approach. And what we're talking about here is establishing a shared vision among the primary care providers and support partners to attach patients in, as I mentioned earlier, a sustainable process that will go and live much longer than working down the current HCC list. We want to make sure that we're consolidating primary care health lists so that there's not duplication, contacting the same person twice, but also clear up any duplication between lists at the primary care clinics along with the Healthcare Connect lists. And then to the extent that we can share resources across the different types of primary care practice models and to help them increase attachment too, because we have everything from large family health teams through to solo practices with 1 or 2 people in the practice. And we have to figure out how to share resources with them to make their attachment process as easy as possible. Next slide. The other 3 that I think are pertinent to this particular session are establishing transitional solutions. Here, what we want to do is, while we're trying to ramp up a process for primary care, you might enable paramedicine to organize themselves locally as a main primary care point, build relationships with walk-in clinics to provide services to patients while they're waiting to be attached. Number 8, establishing hybrid attachment models. This is something that I think is very appropriate for Central Ontario, where we have a lot of people that migrate to cottages during the summer. They may need primary care, but they have primary care in their other locations or their primary homes, as well as students that move around the province, and making sure that we can attach them while they're at school versus when they're at home. And then finally, this is really probably a tough nut to crack, but improving the supply and distribution of primary care providers. How do we undertake HHR planning and recruitment and retention to keep providers, to get more providers, first of all, because we need more providers, but also to keep them and make it joy and work, basically. How do we make sure that it's not just about hiring providers, but making sure that they're actually enjoying the work that they're doing? Next slide. So that was just a sort of overview of how what you've told us you're doing can be applicable to this particular session. We're going to have three presentations around folks that are looking at how they measure need, demand, and supply. And then we'll have a discussion after that, and then we'll have one of the RISE coaches, Lori Zagar, to talk more to us about that measuring need, supply, demand, and supply. But we should probably start with some definitions to begin with. When we talk about need is the capacity for an individual's health to benefit from the consumption of a specific good or service in a given situation. Bit jargony. I like the examples. Perfect. Example: someone living with diabetes needs to receive chronic disease management or diabetes education. So that's what we're talking about when we talk about need. Want is the desire to consume a specific good or service. So again, the example would be patients may want a primary care provider that's close to their home and they don't want to wait for an appointment. So that would be an example of want. Demand is want backed up by the willingness and ability to actually access or use a specific good or service. So again, the example here is the demand would be the number of primary care appointments that are accessed or used in a year, week, or a month. So part of that, what we're going to learn today is how do you measure that demand within a given primary care practice. And then supply is the amount of commodity or service that is available. So you may have a certain demand, but your supply is the actual number of appointments in a primary care clinician schedule and the number of primary care providers. So just some baseline definitions to help you as we start to go through the presentations here, as well as the follow-up around measuring need, demand, and supply. Okay, Leslie, thank you. I'm about to introduce the speakers. I've worked now for, I forget how many years with Brianne Wood, but before you all came on, I couldn't remember what her title was. So Leslie just put it in the chat. So Dr. Brianne Wood is an associate scientist at Social Accountability and Learning Health Systems at Northern Ontario School of Medicine. She's also a co-lead at RISE to help us work in the North. And she and her team have done terrific work. We love working with her. So Brianne, take it away.
Awesome. That was a great intro, Mike. Thank you. And thank you, Leslie. Hi, everybody. Many of you have heard me speak before. You might have even seen these slides before. I do want to preface my talk. You're getting a little snippet of my presentation tomorrow for Trillium Primary Healthcare Research Day. But also that I have been working in the primary care recruitment retention space for a long time. This is the medical school's bread and butter. It's why the medical school exists, is really to bring more, primary care physicians, but really strengthening healthcare in Northern Ontario. And so what I'm talking about today is some specific work that my team and I have been working on in the Northwest. And so I've indicated some of my co-authors here. Next slide, please. And again, if you've seen me present, this is one of my common slides. So what is our context? There are 11 Ontario health teams in the North, 4 in the Northwest. Primary health care, I've got an image of an orange plane, not typically delivered on an orange plane, but could be delivered in the air, might look completely different than it looks in other places, could be delivered in other settings, and really does look different because of the different capacity needs and different contexts. We collaborate. So integrated care systems, we have to work together across Ontario health teams, across sectors, because we have to, and we always have. And so I'd say that that's really one of our strengths. And also, I mean, I talk about Northern Ontario or even just Northwestern Ontario, but really there's a lot of diversity across the region that takes up about 90% of Ontario's landmass, although only 6% of the population. But we really do have a lot of diversity. And so really wanting to point out that our needs do vary across the geography. Next slide, please. And so again, wanting to really emphasize, we've been working on this for a long time. So not to suggest that this is something that can be done, you know, in a quick 6-week turnaround, but as Mike identified, this project really started with understanding the distribution of providers in primary care and how do we align the needs and supply. And so we adapted actually a framework that I know one of the other OHTs will be speaking to later on. We adapted Simkin et al.'s framework into this more simplistic model to understand how are the primary care needs aligning with supply, and then what might be possible solutions to address any gaps. And we did this in a number of ways. So on the right-hand side here, what we did is we used a geographic segmentation approach that was validated by local health system decision makers and community leaders. And then we started to actually use existing data sources. I mean, we had this goal, and I'll speak to this awesome new data package we got that's helping us, but we actually had to work with existing data packages to be able to populate the needs and supply modules. And I'll dig into that a bit in the next slides. My colleague Jin Fan, who I believe is on the call, did some of this work over the summer, and I'll speak briefly to that. We also collected our own data. So how do we add the qualitative insights and actually get robust evidence that describes what we all know is going on, that the numbers aren't completely covering the story. And then we actually got Inspire PHC finally in the last couple of weeks. We actually got an additional data package to help us understand primary care needs and demand, primary care supply, and how do they compare. And so that I'll talk a little bit about that. Next slide, please. And so Mike is so happy for that needs, supply, demand slide. So this is what we did. And again, this is a slide that we actually presented to Ontario health teams when we were first getting started. How do we populate those different modules? So in terms of understanding needs, we thought of the available population health information. You'll see some examples listed on the right. In terms of unmet needs, again, what is the available information that we can tap into that might give us an understanding of what those needs are. As Mike's slide denoted, demand, or what is actually being used. We tried to look at, again, available information, usually coming from those Inspire reports. And then as you'll see in the right-hand blue box is, you know, do these resonate with the OHT? So this was something that we presented out. Next slide, please. And then from the supply module side, we actually had really two distinct modules here. We separated physicians because the amount and detail of information that we can get on physicians is quite different than what we can get on interprofessional providers, which I'm sure many of you know. But also the contracts and different sort of practice characteristics influence the type of data that we can get. So really emphasizing that we got head counts, so number of actual bodies practicing, as well as full-time equivalents. Next slide, please. So one of the outputs that we did, Jin Fan and our team produced over the summer, which was a heat map. And this was really, the focus of this was to provide a sort of within the Northwest comparison across OHTs. where are the priorities? Where are the biggest gaps? And what are the implications there? And so on this slide, you'll see an example of what the heat map looked like, our way of synthesizing multiple types of information that was readily available to us into something that was a little bit more consumable, that health system decision makers could look at this and say, oh, okay, this is where the needs really outweigh supply, or okay, in this domain, we're actually seeing a little bit better alignment. Next slide, please. Some of the qualitative data analysis that we had was really, really impactful and helped us contextualize some of the routinely collected data. And so I pulled from Manila's work that she's also presenting at Trillium Primary Healthcare Research Day on some of our primary data collection. And this is really interesting, coming back to some of those 9 strategies for strengthening primary care. What are those different supports and what do they look like to help us come up with some change ideas? Next slide, please. I apologize. I know I'm like breezing through these, and there's so much that I'd love to chat about, but I'm trying to respect my colleagues' presentation time. And at last, a couple of weeks ago, actually about a month ago, we finally received, after a year in request, we finally received some data, some extra data from Inspire PHC. And this was really cool because we got it at the geographic segmentation level. That was helpful for us, but also looked at the different variables. So we looked at primary care supply in terms of number of primary care visits given over a certain year, over the need. And the need was determined using the CHI populations grouper expected visits, expected primary care visits. I can link you to some more information on that if you'd like. This was really what we were looking for. And as you know, I'll just briefly tell you what this is telling us. But in the first row, we're seeing supply over need. So the number of primary care visits provided in a year over the total expected number of visits from that population. And we're less than 50% in almost all of our hubs. Now it looks a little bit different if we look at primary care visits provided in any setting versus just in clinic. We're actually seeing a little bit better alignment. And then when we're looking at the proportion of primary care visits provided in office over any type of primary care visit, again, we're looking like, oh, okay, so actually a lot of our primary care visits are probably in Emerge, which again, we know from our survey and from working closely with providers that that's how some of the emerges stay open. So some deeper digging that we need to do. Next slide, please. And so I'll just wrap it up quickly here. Again, really understanding the difference in needs, demands, and supply, and trying to understand alignment has been really helpful for us. But we're also realizing that we need to push it, and we need to think beyond just matching the right number of providers with the exact right type of population need. Although that is a critical part. And what really stood out to us with this whole process is the need for locally relevant data done in a geographic way that makes sense to us in Northwestern Ontario, and ways to synthesize data that is readily available. So I will wrap up there so that I can pass it to my other presenters. Thank you so much.
Wonderful. Thanks so much, Brianne. I love the little graphic on your last slide there, the Venn diagram. Wonderful.
Yeah.
Okay, terrific. So we're now going to move to North Toronto and the work that Dr. Susan Joyce has done. And she is the co-lead from the North Toronto Primary Care Network. And presenting along with her is Kitty Liu, Director of the North Toronto OHT, and Kitty Pang, who's a project manager and supporting North Toronto OHT in the PCN work. So take it away.
Thank you very much, Mike, for that introduction. Hello, everyone. I'm Kitty Liu. Thank you very much for the opportunity to share with you our journey in North Toronto. This is a great opportunity to hear what others are doing, and we're happy to share with you our journey as well. So like many of you, we know we have a problem with the number of unattached patients we have in North Toronto. We're hearing it from the patients. We are seeing it in the paper. We, as an OHT, has been preparing a list of primary care physicians who are accepting new patients so that we can share it broadly with people who are looking for a family doctor. Now, that list has dwindled from the 6 pages a couple of years ago, pre-pandemic times when we first started, to just 1 page in recent years, so we know we have a problem. We have raised this issue many times with our OHT leadership. Their response to us was, stop re-diagnosing the problem. We know this is an issue, but tell us the magnitude of the problem so that we can do something about it. So that was the start of our journey when we started out working on how big our problem is from a demand and supply perspective. On the next slide, just some of the data that we have been using. I'll say that the easiest data for us to access, although not representative of the problem, is hospital data, where we are seeing between 20 to 25% people of coming to the Sunnybrook Emergency Department without a primary care provider. So of course, that also raised alarm bells from a hospital perspective. So we're trying to figure out more in terms of what is the actual problem. Now, through the primary care action team data package, which all of us have access to now, we know that we have 30,000 people unattached in the 8 4 sortation areas, the postal codes that are assigned to us. But that was data that has been only available to us recently as we started the primary care action team work. But we actually started this analysis back in 2023. We were lucky at that time that there was a collaboration between the health analytics team at Ontario Health Toronto and researchers from the Canadian Health Workforce Network. Together, they developed the Primary Care Workforce Planning Toolkit, which was informed by extensive consultation with partners, including the City of Toronto, as well as decision makers, health system leaders, and primary care providers. Now, Brianne, it sounded like you did a lot of work on your own end together with your team. I will say that we were a bit more lucky that we had a team of researchers behind it to share with us the toolkit, which I think I have tried to share the link through the chat, so maybe the folks online can try and access to take a look at that toolkit that was available to us for in Toronto region. Now, the toolkit provided us with a lot of information related to current and projected future state of population health needs. And from a primary care service provision at a neighborhood level within the City of Toronto. So that allowed us the opportunity to focus on what may be high priority areas within our OHT that we should be focusing on. On the next slide, just a snapshot of some of the data that you can access through the toolkit is that you see that from a neighborhood level, there is actually a neighborhood called North Toronto within the North Toronto OHT, very confusing. But you can see that the population growth of that neighborhood is at 151%. So significant population growth, but without an equivalent increase in primary care capacity. So we know that we have a problem in this neighborhood. Now on the next slide, what you see is that, on the top, the increasing physician service requirements based on, patterns of access. So we also know this is an increasing demand area that we need to focus on if we are to address the number of unattached patients that we have in North Toronto. On the next slide, with the data that we have across different sources, we have identified that, from a demand perspective, we need a lot more primary care providers in the Mount Pleasant area. This stems from the significant population growth that we're seeing. But also from a population health perspective, we're able to see from one of the neighborhoods, Angle Mount Lawrence, which is towards the star on the left-hand side of the map. There is a high needs from a chronic disease perspective. It has the highest rate of chronic diseases compared to the other geographies in North Toronto. So from a population health perspective, that also speaks to us and tells us, informs us the demand that we need to be looking after in our geography. So those are some of the data that we have seen, and I'll pass it over to Dr. Susan Joyce to talk more about understanding our supply and demand in primary care.
Thank you so much, Kitty. And yes, this is definitely a whole OHT approach, because I have a fantastic team at North Toronto. The two Kittys are here with me. Yes, so that's the background of the crisis we found ourselves in 2023, and we used that information that Kitty has just described to build our model. We've been doing a lot of engagement with our primary care providers to understand the current supply today. We did a census earlier this year. You probably realize that through the DFCM and other organizations. So we have a better understanding now, as the PCN has grown in maturity, about the providers and the types of practices that they practice in. We understand from that engagement that many of our physicians are older, many of them are in focused practice rather than comprehensive practice, and the rents in North Toronto are skyrocketing, and many physicians have to leave their current practice. As Kitty mentioned, the hospital data has confirmed that many of the patients who end up in the emergency department don't have any primary care. We've also, through our engagement, project managers, done a lot of engagement with our local communities to understand what their needs are and where they are getting healthcare or not at the moment. And we understand that one of our biggest populations who are unattached, and whether they have demand or need is to be ascertained. Men, young adult men, are largely unattached in North Toronto. We also know that from the aspect of team-based care, that our residents in North Toronto have much lower access to team than anywhere else across the province. So go to the next slide, please, and we'll just to discuss a little bit more about how this has affected our strategy towards the attachment challenge. So we're very interested in retention, as has been mentioned already, because retention is very important to maintaining our high levels of attachment or achieving our attachment goals. So with our primary care network engagements, we have created in 2023, actually even before Jane Philpott's model, this hub and affiliate model. And the description of this model is really a primary care hub, a physical space with primary care access and allied health access located at the hub. But the hub is in close relationship with the affiliated local practices surrounding the hub. And that allows access and attachment locally based on local needs. What I mean by that is understanding the local population. The local providers could employ allied health based on the profile of their population. Yeah, so as I said, the whole OHT and our hospital support partners have been invaluable in this work. And in round one, we have been granted our proposal to attach 10,000 people this coming year. And we're working on this at the moment through this hub and affiliate model, expanding access to team-based care at our hubs through allied health employment, and locating our allied health professionals within our affiliated practices. So this has been, the practices have told us that they want and need to have dedicated people within their offices rather than a person who's available by phone call or, by consultation. And so through this, we're building relationships where the care can be very much integrated as people learn to work together in teams. So we have 2 hubs at the moment, who are working with affiliates. So we have 5 affiliated practices in this model, this hub and affiliate model. So we're employing allied health at the hubs and also with the affiliates. So we're supporting the affiliates through employment at the hubs. We plan in round 2 and subsequent rounds to extend our model to 5 areas, because we know that we have about 30,000 more after the 10,000 we plan to attach in round 1. We have 30,000 more, which will require 2 more hubs. And based on the information that Kitty has shared with you, we will target the areas of greatest need in the northwest and the northeast of our geography, and through our plan is through those hubs to attach 30,000 more people using this team-based model, using co-design with our primary care providers and our teams. So thank you for your time, and we will be happy to share any other information that we have. Yes. So we have received 8 expressions of interest in our round 2 proposal, which we received yesterday, and we're planning greater expansion with some challenges. Thank you.
Thank you so much, Susan and Kitty. That's terrific, great information. And our final presenter is Deanna Huggett, who's the Executive Director of Elgin OHT. I think you've probably guessed what we've tried to do is have presentations from not only an urban center, but also a more rural center, or dealing with a more rural population, as well as the North, which has a very unique set of challenges. So here's Deanna to present from Elgin, which is more of a rural OHT. Go ahead, Deanna.
Thanks, Mike. And yes, you're absolutely right. We are a small OHT. Our population is only about 105,000. We are situated in southwestern Ontario, and a small rural region. And just, some of the other unique challenges, or not challenges, the unique aspects of our population are we have some significant mental health and addiction needs within the community, as many others do. We also have one of the largest Low German, Amish, and Mennonite populations in the province. We are also known as a tobacco farming community, and so there have been significant impacts there in relation to chronic disease, and particularly lung disease and COPD. And we have high levels of material deprivation, where we are the 5th in Ontario, not in a good way. So I also just wanted to share, and we've had significant population growth. I know it was just mentioned that there was significant population growth in the Toronto area, North Toronto area as well. We've had success in bringing some great industry to the region in terms of an Amazon plant and an EV battery plant, and that has offering some unique opportunities to think about partnerships with industry as we also connect to health. And because we're located on the shores of Lake Erie, we do have lots of retirees coming to the region as well. We're successful in receiving funding through the 2023 expressions of interest for the interprofessional primary care team funding, and I'll get to the opportunities and the successes that has allowed us to have within the community, and really building some foundations for our future work together around integrated care. So I will get into this slide here now, and what I did want to share is that we're a small OHT, and we have also, over the last number of months, been a very small staff team. So of 3. So our staff team has been 3 people. That's what we've had access to over the last number of months for a variety of reasons. And so coming from a really limited resource environment, where we've needed to lean exceptionally on public and the provincial assets that are available to OHTs, as well as our members. We're fortunate to have a very collaborative community, including our primary care community, which has allowed us, not to necessarily have a lot of formal resources. Those are fairly low, but to be able to lean on our community members. And Brianne, your statement about collaborating because we need to and always have really resonates. That's a strong approach in our region as well. We have also really leaned on our population health coaches at RISE, and I'm very grateful for the support and guidance that they are able to offer and that provincial resource available to us. And we have also been able to lean extensively on partnerships with Western University, which is not too far from us, and have a number of students who have helped us. So for example, over the course of the summer, we had six master's students in health informatics and/or business analytics that were able to help with some of the data needs that have allowed us to get to the point where we're at today. And then, to others' points in terms of just a few little things where, we didn't have staff, we weren't able to do hiring in time, a couple of small support contracts to do a little bit of data analysis have helped us along as well. So, understanding our population needs, just mentioned the who in terms of the resourcing, really low, very low touch approach, but we did with this low touch approach look at building a bit of a plan to collect the information that we need in terms of understanding population needs, the primary care demand and supply, and ultimately informing a neighborhood health home model, which I'll get to in a few minutes, that is allowing us to have that foundation from which we are now expanding and improving our access and attachment plans and building our next primary care proposal. The quantitative data sources that we use: census data, OHT dashboard data, Inspire primary care data, HSPN data, so very accessible points of information to us. The other key one, which I'll get to in a few minutes, has also been reaching out to our members for some information, and we're grateful to accept their kind contributions in time and pulling that information for us. In terms of qualitative sources, a lot of engagement across the community, interviews with our OHT members and partners, specifically around our equity deserving populations, to understand what they're seeing on the ground, and build that into the model and make sure that it kind of reflects some of the data that we're having, but also acknowledgement of where there are some gaps. I've put a couple of slides up there, not just, not for you to see the content that's on there, but more just, again, kind of that simple. We don't have a lot of fancy tools or the ability to have capacity to train in tools to pull stuff together. So we're using a fairly simple approach of just things that we have available to us and comparing our population to provincial averages and sharing information about, where we may differ and how we differ across some of the local regions. As with some of the North folks, some of those FSAs are fairly large in our rural geography, and that's where we really rely on some of that qualitative data information that we don't to help build out sort of the more local context. I will acknowledge our population needs in terms of, we've got about 14% unattached, but one of the more unique needs is that we have 23% of folks who have access to primary care outside of Elgin. So Mike, referencing some of that seasonal approach, we do have some seasonal migration patterns here as well, but really a lot of folks that access care outside of Elgin, and I'll get to why that's particularly important in a minute. Oh, if you could go to the next slide, please. So the understanding our primary care demand. And so we have one hospital, we have one fantastic emergency department. They've been either number one or two in terms of that emerge flow in the province, which is amazing, and very heavily utilized by our community. We also have one walk-in clinic. We are a rural and diverse geography. We only have one walk-in clinic that's open a few hours each week. So again, that directs lots of folks to the emergency department, and so gathering information from them has been critical for us. We also, through the 2023 expression of interest, we were able to pull to start a clinic for those who don't have a primary care provider, and that has been extremely successful. And so over the course of the first year, was able to actually see about 5,000 people in that unattached clinic. And so we're getting some fantastic data from them, and that has been a really successful approach in terms of a whole of community approach and a great partnership with the OHT staff team, which we are now leveraging for our next iteration. And we have community paramedicine. So our community paramedicine is only a couple years old, so that's a new program, and we're growing together with that program. But those data sources have been able to, in addition to kind of some of the primary care data that I'll talk about in a second, have been able to help build us a little bit of an awareness of, what's, how many folks are going to the emergency department that are have primary care in Elgin versus outside of Elgin. How many folks are, where are they coming from in terms of the region, and also, understanding a little bit more about why people are accessing, for example, our unattached clinic. And what we see, for example, there is that a lot of it relates to chronic disease management as opposed to some of the more acute care needs, and that also helps us understand where we need to go. So we did have a survey that was developed. So our students were able to develop one set of students developed a survey for us and reached out. And then another set of students was able to kind of review some of that data. Our primary care network is heavily engaged, and we've got some direct engagement with physicians and nurse practitioners now through a survey template. Some of the things that we've been asking about are, the volume and capacity around who is most frequently accessing services, and how does this align with capacity and current unmet demand. So, total roster size would be an example within that category. Geographic distribution of people served. Where do people accessing care live? As I just mentioned, where are we effectively reaching priority populations across our geography? And so, for example, we have, there's a successful mobile unit that has been going out for a number of years, and we were able to pull information on from that as well, and understand where there's some gaps and where could we be able to support that mobile outreach in other areas. Appointment access and attachment changes, how timely and accessible our services, how our attachment patterns shifting over time. Number of newly attached folks would be an example of a data point that we've been able to pull from our teams there. Visit types and care patterns, what kinds of care are people seeking? How do visit patterns reflect population health needs and service mix, like the reason for visit I was just mentioning. And then provider staffing and clinical capacity. So what is that actual capacity like, and how does it compare to demand? So being able to access FTE by provider type information, for example, from our primary care teams, and understanding how well those services are being utilized. If we could go to the next slide, please. So getting a little bit more at understanding primary care supply, like others, understanding what services exist from our teams, what services exist for people who don't have access to a physician or a nurse practitioner, being able to pull that information together, who can access them, what are those restriction points. That low German, Amish, and Mennonite community, for example, there's a lot of folks who don't have access to OHIP cards. And so that is really important when we're contemplating our model. And, one of the things that we have seen is that the folks who don't have access to primary healthcare cards in that new unattached clinic, that's been a large portion and a shifting portion in who's accessing that clinic. And so again, it's something that we need to plan for. Who provides these services, what are the waiting lists, and community strengths and successes. And, I mentioned, for example, that we have 23% of our residents that have access to primary care outside of Elgin. We also did a survey a couple of years ago with our existing physicians and found that anywhere between 9 and 14% of their rosters are for folks who no longer live in Elgin as well. And so a significant opportunity of how do we support that care close to home model, and how do we work with other OHTs to think about what's the best approach to supporting care close to home and making those experiences and outcomes better for everyone. There is a local healthcare recruitment partnership that has been supported by the municipalities locally for years, which is great, and have had some success, which is fantastic as well. So we've had a number of new physicians come to the region. One of the challenges with that is that that completely shifts any of the data that we have, in terms of a lot of that data is no longer relevant because we've had several new physicians come to the region. And so a little bit of on the ground work to try to make sure we connect with those folks and understand their capacity needs. Interestingly enough, just at a very subjective or anecdotal level, I will say that those new physicians coming to the region, 60% of the people they are rostering are from people who are attached to a physician or nurse practitioner in another region. And so from an equity perspective, we're not necessarily capturing always the folks that are unattached. And we know that some of those folks that are unattached are not getting the information that they need about those new physicians coming to the region. So it certainly does impact our plans that way. Next slide, please. Through all of this engagement and the planning and understanding what we have done over the course of the last few years, really leveraging the assets we have built a neighborhood health hub model. This was just approved actually last week, which we're thrilled about. And now using this as the foundation for the next planning or the next proposal that will go in. So it will really align to that work. So we have a central hub with 2 spoke sites, leveraging the CHCs and the family health teams in our region, and satellite sites. And so this is, understanding some of the satellite sites that we already have. One's in a local shelter, one's in our social services building, and through the kind of hotspot data that we have from our hospital, from community paramedicine, from our engagement with our equity deserving populations, we're better understanding some of those spots where additional satellite sites will be used. We have community paramedicine, we have a mobile outreach unit. That mobile outreach unit, was only able to be resourced 1 day per week and otherwise has been sitting in a storage facility. So a great opportunity for us to be able to expand and access resources there. And bringing in academic affiliation. We don't have an academic site, and so thinking about how we build that into our model, but also in a way that maximizes the hub and spoke model that we have just all committed to. So we're very excited about that. Very excited about the opportunities to bring some of that leadership together. And finally, here's just a couple of the points here, is that it's care close to home, hub and spoke model, satellite sites and mobile outreach, centralized waiting lists, supported intake, referral navigation supports, coordinated after hours care. This is much of what many others are doing as well. And then that academic site. And what's next is building out that phased implementation. What do we need resources for and what can we do locally? And then the attachment commitments in terms of the current funding proposal, all aligned to this model. And then, starting to implement where we can. Thank you.
Thank you so much, Deanna. Thank you to all 3 of our presenters. We have some time for Q&A, about 20 minutes, maybe 15 minutes. So please come off mute and ask your questions. While you're thinking about what your question is, I will ask one from Saba Eftekari from AFTO. And her question was, she was wondering what you would suggest for measuring unfulfilled demand. I believe unfulfilled demand is not equal to unmet needs. Knowing how to measure unfulfilled demand really helps us plan for more attachment as a low-hanging fruit. Those are the ones that have already knocked on our door. I don't know the answer to that question. So anyone want to jump in? Lori?
I can jump in, Mike, a little bit. Absolutely, the unused demand is not equal to needs, because as we defined demand, it could be part of that, but it's also the people who have actually tried to access the system and couldn't. So sometimes when working at the practice level, we can look at phone calls that came in that weren't answered, people that, you know, dropped calls, those kinds of things. That's why we measure ED visits too, because if people can't get in to see their primary care provider, they sometimes go to emerge. So this is kind of the hidden. You need to make some assumptions, knowing your needs, knowing your community, and then you can start to dig into it and understand it from a almost an assumptions point of view. So you assume that people can't get into, they're making the demand on the system. They can't get into the system because the system is full, if that's what she was defining it as. So how do you get at that? They couldn't get into their primary care provider, they went to their ED visits or to the ED department. You know, they were trying to access, they were on the phone for too long. That's a really micro level, but drops called are sometimes what we looked at when we're looking at access into provider level. So it is kind of a bit of a hidden one when you're looking at demand as trying to access the system, and the demand was unmet. So you kind of have to dig a little bit and really define what you mean by it. So I don't know if that helps or just made it more muddy.
Great. Thanks, Lori. Other questions people have?
You know,
Yeah.
maybe I'll also attempt to answer that question from North Toronto's perspective, because we anticipate the questions will come in terms of how do we know we're successful and that we are making an impact. The system level data is harder to come by, as I have said in our presentation, that the easiest data comes from our hospital because of the close association and linkage that we have. To Lori's point, you know, one of the indicators that we have set up for ourselves is looking at, you know, if right now we are seeing 20 to 25% of unattached patients coming to our ED, if we're increasing our attachment, if we're starting to, you know, address that 30,000 people unattached in North Toronto, do we anticipate seeing a reduction of number of unattached patients coming to the ED? So that's one data point that we will be looking at. Whether that's the appropriate one, we don't know. We'll see if we move the dial a little bit or not, but we certainly anticipate seeing, hopefully, a reduction of CTAS 4s and 5s, which are the less complex conditions of those type of visits to our ED department.
Thanks, Kitty. Rob, I want to call on you because you raised, you and I were talking, and I think it's Rob raised an important point. We've been talking in a very technical way around need, demand, and supply, but Rob has raised the issue of what are we actually attaching people to. So, Rob, please go ahead.
Thanks, Mike. And you guys are just doing superbly. I'm one of the co-leads of RISE overall. So, and I've just been listening to the presentations and remarkable work that you're doing. This is a real difficult balancing act and trying to get all these things right at the same time. So you're really thoughtfully doing this. Remember, the overall purpose of this is to really deliver high-performing primary care. And the principles of high-performing primary care are really based on relationships. It's creating longitudinal relationships between individual patients and providers over time that last. And we know the benefits that come with continuity to that. There's tremendous health benefits that come with continuous relationships. But you have to provide access to those continuous relationships. So as you're thinking about attaching, make sure that you're also thinking about creating relationships, and making sure as you're thinking about access, it's access to those relationships. So you want to really foster that. It's a challenge to provide access and continuity at the same time. They're both important, but it really is important that you consider this together. And one of the solutions around how to provide access to your doctor is to expand it, or your nurse practitioner is to expand it to your team. Right? So that the team now can expand and provide access, a team that works together. And that's the way that most groups across the world really try to balance this conundrum of making sure everybody has a doctor or a nurse practitioner and they can get in to see them when they need it.
Great. Thanks, Rob. Susan, I see your hand up.
Yeah, just to comment on that, that's what we found in North Toronto. We have had access to an IPCT team who, gave piecemeal services to our providers, but relationships were not developed. And so in our round one funding, we have underlined that we want real relationships to build by having people in the office working with the physicians and whoever's there, because this team-based work is not something most of our physicians are familiar with, in fact, and there's going to be a bit of a learning curve, and embedding the people physically in there is necessary. So virtual attachment is not going to be, as you described, the really high level attachment. So I agree fully.
Yeah. It's a great point, Susan. And just so folks know, our future webinars will be looking at this. How do we create high-performing, not only primary care, but primary care teams? And so stay tuned for some of that. Kay at Nujmawing, she asked a question. A shared wait list was a topic listed as a focus at the beginning. What steps need to be taken to achieve a shared wait list? And Kitty, I think you answered, but if anyone have any suggestions around a shared wait list? I'm assuming that Kay is asking outside of Healthcare Connect.
It's Deanna. I can share our plans if that's at all helpful. Not yet fully implemented, but our plans are to leverage the lead agency identified as the Healthcare Connect health information custodian. And that also is the lead agency for our Elgin Community Health Hub, which is our new clinic for unattached folks. And so we are starting to build commitment across the region from our physicians and our primary care teams to try to drive folks to that organization, to that hub, where we will build out that centralized wait list. Also identifying what the resources are required in order to be able to manage that from a data, administrative data support perspective. So not fully done, but that commitment across the region is a critical part of it.
Wonderful. Thanks, Deanna. Kitty?
I just want to add to my answers that we're doing various type of engagement, within North Toronto to try to identify those who are looking for primary care providers. And of course, we're working with our community partners, our hospital partners, to ensure that they're aware that, we have a supportive intake where we are collecting information to identify those who are looking to be attached to a primary care provider. But what is unique about our supportive intake process versus the Healthcare Connect waitlist is that we do have a team of clinicians looking at the needs and trying to address some of those needs and identify, the complexity levels, and then attaching them to the appropriate clinics that are available and looking to attach patients. So I just want to make sure that we do have a clinical aspect for this. So it's not just a wait list, but it's a little bit more involved.
Perfect. Thanks, Kitty. Kay?
Yeah, sorry, just to follow up. We have a lot of clinics with their own established wait lists. Trying to navigate privacy to combine existing wait lists is sort of where we're getting stuck. And I stepped out at one point, so I might have missed a few folks have addressed that already.
Sorry, Kay, I didn't catch the question though.
Sorry, the question is what steps could we take to be consolidating existing wait lists, navigating privacy laws?
I see. Susan, go ahead.
Yeah, we've also come across that challenge and haven't quite ironed it out yet, but it is a problem when you're collecting this patient information outside of a clinical care setting. So that is the challenge, and we haven't solved it yet, but yeah.
I think it's a question that we can take back to the privacy folks and see if we can hopefully get more direction on that. I
Thanks,
want to
everyone.
raise a point that Anna raised. Oh, sorry, did I cut somebody off?
I was just saying thank you. Go ahead.
If I may add to Susan's point, yes, definitely agree that it will be difficult to share wait lists. But given the central intake model that we are doing, we want to see if there's an opportunity to share the link to that central intake for people who are already on the wait list, so that the work of managing people who are waiting for primary care can be more centrally managed by the OHT. And that is also our attempt in, what the term is called level loading, and not to make one particular clinic's wait times very high, because what we want to do is also look at the next available primary care who has capacity to take on new patients, rather than having individuals only wait in for one particular clinic. Because I think access to care is important. Timely access to care is important. And while there may be some preferences that individuals has indicated in their request, we will try and match them up with what their preferences are as much as possible. But we also want to be able to facilitate and liaise with the individual to say, we have this option for you right now. It is convenient, is where it's located, close to your home, and see whether those options are available. But agree, I don't think we have the opportunity to combine waitlists at this time, because from a privacy perspective, we don't have consent to access those information. And this can be seen through the process that Ontario Health at Home has to undertake to allow OHTs and primary care networks to access the HCC waitlist, which has taken a very long time. So I don't know how easy it will be to take waitlist information from our local primary care providers.
Thanks, Katie. Anna from Nujmawing raised a good point. I think it can sometimes be the elephant in the room. With this rush to attaching patients, are we going to kill access? Jump in, Lori.
I'm going to talk a little bit about that in a few minutes, but absolutely that is the risk. That is absolutely the risk. But there's so many opportunities that'll be the next wave of work, because there are opportunities to, when we build trusting relationships within the primary care team, then we can start to share the care, we can start to do, and that's going to help address this access. But initially, yes, we will probably see that access, that's the risk, but there's lots of things we can do. Team-based care, it's not just about adding more clinicians, it's actually how do we use those clinicians better, more appropriately? How do we use our allied health? How do we use our nursing to full scope of practice? So there's lots of work in the last 20 years that's been done on access. It's just really hard because you have so much on your plates right now to say, how do we do that really hard work to prevent access? And how do we do that attachment? So it's hard work, but I do think there's things we will do. It will be a little bit bumpy till we get there, just my opinion. But there are things we can do in terms of addressing the access challenge.
And Mike, I'll just add to Lori's, comment, really good, Lori, is, I'm really glad we heard that question today, because that is the challenge. It's we want to get patients and our people in Ontario someone to attach to, that's their doctor, their nurse practitioner, their team. But it doesn't work very well if they have no access to that doctor, that nurse practitioner, or that team. So not only do you have to think about access, you actually have to think really now about attachment, but you really have to think now about access, because you don't want to, tell someone that they have a doctor and then they can't get into them. That's not particularly a good way about it. So it's a great comment. There are a lot of different things you can do to maximize access, as Lori was talking about, and the coaches will really be digging into maximizing capacity for those patients that are now attached.
So we're at our time. Thanks, Rob. Thanks, Lori. We're at our time for Q&A. I do want to just wrap up by saying that if we didn't answer your question, please reach out to any of the coaches. You have our emails. If we don't know the answer, we'll get you to someone who does know the answer. We know that a number of teams are struggling with working down the HCC list for a variety of reasons. But we're going to also try and help and smooth out some of that process for you. I think the important thing is if you're just getting started on this journey, there's lots of questions that you'll have. Pose those questions not only to us, but our presenters here who are a little further down the road. And with that, I'd like to hand it over to Lori Zagar, who can give you some tips on how to measure need, demand, and supply, and attaching people to a continuous relationship with a primary care provider. So Lori, hand it over to you.
Thanks, Mike. And thanks to the presenters, amazing work. I'm not really going to give too many tips and tricks. I'm talking about sort of an approach and then how the RISE coaches will approach that. When we think about supply, we've heard these words a lot over the last hour: supply, demand, supply, demand. It's really important to remind ourselves that what we're seeking is the balance between that supply and demand. And why? We remind ourselves of the why. I know you all know it. I know we all know it. It's timely access to care to a provider that you have that longitudinal relationship with. It's that continuity of care, but timely access, that push-pull. So when we're in balance, that's when the system works. And as we've just talked about in the last few minutes, the access to care will be the next mountain to climb, so to speak. Next slide, please. So in terms of supply and demand, just wanted to kind of say that there are some strong methods that have been developed in the last many years around measuring supply and demand at the practice level. So we can calculate the total number of appointments by looking at, appointments per week. We often measure it for a month and then look at averages for a week and multiply it by the time or the number of weeks worked annually. And that gives us the total supply of appointments for a provider. We also, at the practice level, when we do this work, we calculate the total demand. So those folks who have actually come into the demanded and had their needs met, that's our visit rate times our panel or roster. This is the work, again, we do at the practice level. And if you're out of balance, then you can increase your supply of appointments or decrease the demand for appointments. Increasing the supply and appointments doesn't necessarily mean increasing the number of providers. And again, I'm not going to go into the weeds of all of the work you can do to address access, supply, and demand at the practice level. But next slide, please. What we've been trying to do at RISE is ask ourselves, how do we take all that wealth of information that's been built over decades across the world in terms of looking at supply and demand to be able to achieve timely access to care with your primary care provider? How can we take these methods from the practice level and apply them to the OHT PCN level? How can we apply visit rates from existing patients and be able to predict the supply of clinicians that we need to serve attributed population? By understanding the needs of the population, how can we build supply to better meet those needs? And that's the beauty of the presentations we saw today. How can we provide differently to get to new high-performing care? How do we influence supply, demand, and the need providers at the OHT PCN level? So while we may do one set of work at the practice level, what are the relationships we need to build at the OHT level? We've heard recently about MOUs and relationships. So we're trying to pull some work together to support you in that thinking of taking those methods and tools and trying to elevate them. If you were on our last call, you heard us talk about a new way of doing some work. So next slide, please. For many years, 5 years at least, Mike, RISE coaches have had these sessions, the peer learning and sharing sessions, where we talk about many different topics to help support you. We've also provided coaching support But a new way of thinking that we're trying to bring into play is these deep dives, rolling up our sleeves, getting into the how-tos of how to do this work. So it's great to have our teams come and talk to you with examples, but then how do you take those learnings and apply them in your setting? And that's what we're calling our deep dives or our deeper dives, and they are new. Next slide, please. Just a bit more information about the deep dives. We see them as improvement sessions. We see them as interactive. We are hoping that we don't just sit and lecture to you. We want you to co-learn together. We'll be at the level of how to, so trying to really roll up our sleeves and figure this stuff out. So getting into the weeds for you to support your acceleration towards your TPA deliverables. How much time's involved in a deep dive? Well, it will depend on the topic. More simple, potentially topic of attachment in terms of the how-tos, we're predicting will be 2 sessions. But if we're starting to talk about optimizing team-based care, might be more. So we can't really predict the time commitment, but that time will be spent in between the peer sharing and learning sessions. And who should participate in these deeper dives? Well, anyone who's leading your primary care work, we hope that this would be helpful to them. So next slide, please. We want to ask a poll. I don't know, I'm pausing because you might have some questions before we do the poll, but let's do the poll. Would you be interested in a deep dive on understanding need, demand, and supply to facilitate your primary care expansions? So let's take a minute and answer that. I don't know if the results will pop up. I don't know. Leslie, Steve, help me out to know when to move on.
There's still some responses coming in, but I think Steve just ended it and shared on screen.
Thanks, Steve. Thanks, Leslie. Okay, so 97% of you. Last month, it was 68%. So I don't know what happened. Maybe different people came, but this is great news. I think we can really do some co-learning together and really facilitate this. So next slide, please. This is just a reminder, if you were on our last call last month, and we did talk about offering our first one. If you weren't on the call, this will be new to you. But our first deep dive or deeper dive is on attachment processes, building reliable attachment processes. There will be 2 sessions involved. The first one will be October 29th between 11 and 12. And the objectives will be a little bit more didactic on that one. We'll be talking about concepts. Excuse me. Then you'll go away, you'll roll up your sleeves, you'll do some homework. We're there to support you in between as coaches. And then you'll come back, and session 2 will be about sharing, co-learning, talking about challenges, and really building together. So that's our first one. If you didn't know about it, or you were thinking about it and you're interested, we can reach out to Leslie. We already have some teams signed up. We're super excited about this. And given your 97% response rate, I guess we'll be doing our next one, next deeper dive on supply, demand, and need. So next slide, please. Just a reminder that our next peer sharing and learning session, it will be November 20th, 12 to 1:30, as always. If you're interested in having an invite sent to your calendar, please reach out to Leslie. That's kind of how we're doing. Her email is not only on the slide, but in the chat. I'm just looking to where we are at. We're at 1:23. If you have any questions about deep dives, feel free to unmute and ask. Or is there anything in the chat, Mike, before we sign off?
Yeah, Nancy Lynn has asked, is there a limit to the number of individuals per OHT who can attend the deeper dives?
Well, my bias would be to say no right off the bat, because if you can bring your team and everyone hears the same message, that's going to be amazing. You're going to come, learn as a team, and then go back and roll up your sleeves and do the work. So absolutely, that would be amazing.
Lori, could you also talk a little bit about kind of what the time requirements might be for OHTs that are interested at doing deep dives and working in this way?
Yeah, and like I said, it's a little bit hard to predict because it's topic related. So we think that the work in between on your attachment process, you're probably going to do some process mapping. you may have already done your process map, so you'll be at the point of you'll be able to kind of analyze it. Where is our process falling down if you have done that? This could overlay if you have a committee. So if you have a standing committee, then it won't be extra time. So we can piggyback on existing structures that you already have in place. I saw just quickly a chat pop up of will they be recordings? We're leaning towards no. And there's a reason for that. These are roll up your sleeve sessions. They're hard to kind of do with the recording, but we'll reconsider if we get lots of session asked for that. So it's hard to predict, but I see that you'll come for your 1 hour session. You'll go back if you have committees, a 1 hour committee meeting that you can piggyback this onto. Great. Otherwise, you might need to book an hour, 2 max in between the 2 sessions. And we're happy to come and facilitate and coach you in those sessions. Does that help?
Thank you, Laurie. And the idea is it fits into your current work that you're doing. So, you will be able to immediately use the work you're doing to meet your TPA deliverables. So we're not visioning it as added work, but just synergized work for the stuff that you're currently expected to do.
And hopefully accelerate your work, that this can be helpful.
Are there any more questions or comments that people would like to make? Okay, Leslie, it'd be very helpful to have Cliff Note versions for the clinicians as well. Have the admin leads go to the deep dives, but Cliff Notes for the clinicians to help move things along. That's a great point, Ellen. I'm thinking this is where we can make good use of AI summaries and pare them down to create those kind of Cliff Notes for the clinicians. Okay, well, we'll give you back 4 minutes of your day. Thank you for all that attended. Thank you, presenters. Those were fantastic presentations. Thanks for all your questions, and we look forward to seeing many of you at the deep dives. Take care.